I was thinking about this right before my ICU shift last night. Nature basically designed the human skull to be like the ultimate fortress.
Oh, absolutely. I mean, it's a complete evolutionary marvel. It's this solid, rigid vault of bone.
Right. And for, the vast majority of our lives, it does this brilliant job of keeping the outside world exactly where it belongs, which is on the outside.
Right up until the exact moment the threat isn't coming from the outside news.
Exactly, when the threat is coming from the inside.
Yeah, that's when things get terrifying.
Because when you step into the neurocritical care unit, you realize that fortress it can suddenly become a trap.
A literal trap, yeah.
When a patient suffers a severe brain injury, whether that's, from trauma, a massive stroke causing cerebral edema, or maybe a rapidly expanding space-occupying lesion, the brain tissue swells.
Right, the tissue expands, but that bone vault.
It doesn't yield an inch, it just doesn't move.
Yeah.
So the pressure inside the skull just skyrockets.
And that is the exact moment we enter a terrifying race against time. I mean, we are literally fighting to prevent the brain from crushing its own blood supply.
Or worse.
Right, or worst case scenario, herniating down through the foramen magnum right into the brainstem, which is obviously catastrophic.
Welcome to the deep dive, everyone. I was reviewing the latest neurocritical care literature last night, and I really wanted to sit down with you, bringing in your perspective as the senior attending to trace the clinical logic of how we actually manage these crises on the floor.
I'm really looking forward to it. It's a topic I'm incredibly passionate about.
So our mission today for you, the listener, is to unpack this high-stakes, adrenaline-fueled world of managing an intracranial pressure, or ICP, crisis. Okay, let's unpack this, because our ultimate goal here isn't just like fixing a number on a monitor, right?
Oh, not at all.
It's to prevent secondary brain injury.
Precisely. And this is a really crucial distinction for you listening. When a patient hits the ICU doors, the primary injury, so the initial hemorrhage, or the diffuse axonal injury from a car crash that has already happened.
Right, we can't undo that part.
Exactly. The physical damage is done. So the entire focus of our field is preventing the secondary brain injury that follows.
Which is driven by all the systemic chaos.
Yeah, all the chaos that trauma unleashes.
Yeah.
Hypoxia, hypotension, hyperthermia, seizures. Rapid tiered intervention to manage those exact factors is what actually saves the brain tissue that is, still viable.
Right. So we really have to know exactly when that secondary injury is starting to occur. And in the literature, there's this concept of clinical neuroworsening.
Yes, the dreaded neuroworsening.
Speaking as a resident, I got to tell you, this is the exact moment my pager goes off at 3 a.m. The nurse just says, the patient's exam has changed. But we have to be incredibly precise about what defines this clinically, right? Before we just start throwing heavy medications around.
It requires a highly, highly disciplined assessment because, reacting to false alarms can be just as dangerous as ignoring the real ones.
For sure. So what are we actually looking for?
We're looking for very specific, objective triggers. So clinical neuroworsening is strictly defined as a decrease in the motor score of the GCS, the Glasgow Coma Scale, by 1 point or more.
Okay.
It can also present as a new decrease in pupillary reactivity, or maybe a pupillary asymmetry of greater than 2 millimeters.
Or bilateral pupillary dilatation, right?
Exactly. Or a new focal motor deficit, like abnormal posturing. And of course, there's the classic Cushing's triad.
Hypertension, bradycardia, and irregular respirations.
You got it.
But okay, I have to push back on this a little bit, specifically on that first criteria you mentioned, a mere 1 point drop in a motor GCS.
I know, it sounds small.
Like, say a patient goes from localizing to pain to just withdrawing from pain. Is that really enough to trigger a full-blown crisis response? I mean, are we just obsessing over treating numbers on a scale instead of looking at the overall clinical picture?
It's a great question, and it sounds minor, but what's fascinating here is the underlying physics of the skull. It's all governed by the Monroe-Kelly doctrine.
Okay, remind me how that works in this context.
So the skull is a fixed box with a fixed volume. It contains brain tissue, blood, and cerebrospinal fluid. Now, for a while, if the brain swells, the body compensates by basically shunting CSF and venous blood out of the cranial vault.
Making room, essentially.
Right. That's the flat part of the compliance curve. You actually don't see a pressure spike at all.
Wow, okay.
But eventually, you displace all the fluid you possibly can. You just hit a wall. Intracranial compliance plummets.
So the curve just goes completely vertical at that point.
Exactly. At that critical point on the curve, Even a microscopic increase in brain swelling causes a massive exponential spike in intracranial pressure.
Oh, wow.
So that 1-point motor drop, it is a blaring red flag that you have totally run out of compensatory room. The brain is starting to get squeezed.
So you really can't ignore it.
No, you can't. If you dismiss it and wait until you see Cushing's triad, which is that classic physiological response to critically high ICP, you are already disastrously late.
Because Cushing's implies brainstem compression, right?
Yeah, the brain is likely already herniating by the time you see Cushing's.
Wow. Okay, so that 1-point drop demands immediate action because the physics are totally working against us. But before we reach for the drastic, heavy-duty pharmacology, the literature outlines this very specific baseline response we have to run through first.
Yes, the tier 0 measures.
Right. We call these tier 0 measures.
Think of tier 0 as optimizing the physiological environment. It is the absolute foundation of neurocritical care. Honestly, if you don't get this right, none of your advanced therapies will work anyway.
Okay, so pulling from the latest protocols, the tier 0 checklist is intense but beautifully logical. We elevate the head of the bed to 30 to 45 degrees.
Right.
We meticulously keep the patient's head in the midline position. We aggressively target a core body temperature of less than 37.5 degrees Celsius.
Crucial step.
We control blood glucose tightly, aiming between 110 and 180. And we explicitly target a hemoglobin level of greater than 7. I mean, sometimes it feels like we're just, adjusting the room temperature before fighting a raging fire.
It does feel like that sometimes.
But let's break down the why, starting with head positioning. Why the 30 to 45 degrees in midline?
It's pure plumbing, honestly.
Yeah.
Keeping the head midline and elevated uses gravity to optimize cerebral venous drainage.
Right.
If the neck is flexed or rotated, you physically kink the jugular veins.
Like stepping on a garden hose.
Exactly. Venous blood backs up into the cranial vault.
Yeah.
And because of that Monro-Kelly compliance curve we just talked about.
That tiny bit of trapped venous blood causes a massive pressure spike.
Yep. You hit the nail on the head.
Okay. And regarding temperature and glucose, I mean, a brain in crisis is incredibly fragile, right?
Yeah.
The metabolic demand is what we're really trying to control here.
It is.
Because hyperthermia drastically increases the brain's metabolic rate and its demand for oxygen. And extreme glycemic swings cause, metabolic exhaustion at the cellular level.
Exactly. You are trying to keep the injured brain's demand for fuel as low and stable as possible. You really don't want it to outstrip its compromised blood supply.
Which perfectly explains the hemoglobin target of greater than 7.
Right.
Because if intracranial pressure is high, cerebral perfusion pressure is intrinsically low, the blood flow is just sluggish.
Very sluggish.
So the blood that actually does manage to make it up into the capillary beds of the brain, it needs to be absolutely packed with oxygen. We need enough hemoglobin to maintain adequate oxygen delivery to that vulnerable, swollen tissue.
Spot on. It's all about the oxygen extraction ratio. And let's talk about fluid resuscitation too, because that's another critical part of tier 0. The literature is very clear about maintaining euvolemia.
But specifically relying on 0.9% sodium chloride.
Yes. Normal saline.
And this is a huge point of debate in the ICU. Because in almost every other critical care scenario, sepsis, general trauma, we've aggressively moved toward balanced crystalloids, right? Like lactated ringers or plasmolite.
Yeah.
So why the strict preference for basic 0.9% saline here?
It all comes down to osmolarity. You have to remember the blood-brain barrier. Normal saline is slightly hyperosmolar compared to balanced crystalloids, which actually tend to be relatively hypotonic.
Okay, so what happens if you use a hypotonic fluid?
Well, if you give a patient with a disrupted blood-brain barrier a slightly hypotonic fluid, free water will rapidly cross that barrier, right down its concentration gradient, and just flood into the brain tissue.
Oh, wow. So you will literally worsen the cerebral edema you are actively trying to treat.
You'll make it significantly worse.
And the data totally backs this up now. The subgroup analyses of the recent SMART and BASICS trials showed that severe traumatic brain injury patients who received balanced crystalloids actually had a higher 90-day mortality compared to those who got 0.9% sodium chloride.
It's a really striking finding. It shows that tier 0 isn't just busy work. It actively prevents the systemic physiological issues that drive cerebral swelling.
Okay, that makes perfect sense. But let's look at the clinical reality for a second. Say we've run the tier 0 checklist flawlessly. The bed is up, the neck is perfectly straight, the temperature is 36.5, hemoglobin is 8. but I'm looking at the monitor and the pressure is still climbing.
It happens all the time.
The physical environment just isn't enough anymore. We need to alter the chemistry of the blood itself to pull fluid out of the brain.
Right.
And that brings us to Tier 1 ICP lowering therapy. This is where the pharmacology gets really intense, and it sparks one of the most classic debates in medicine. Mannitol versus hypertonic saline.
Ah, yes. The great hyperosmolar debate. It's a classic for a reason. Both of these drugs are heavy hitters, and they work on the exact same fundamental principle.
Which is creating an osmotic gradient, right?
Exactly. They create an osmotic gradient in the intravascular space. Because they are loaded with solutes, they pull free water out of the swollen edematous brain tissue right across the blood-brain barrier and into the bloodstream where it can be cleared.
So looking at the standard dosing in the sources, for 20% mannitol, we are pushing 0.5 to 1 gram per kilogram as a rapid IV infusion.
Right.
For hypertonic saline, and we're talking the really concentrated 23.4% solution here, it's 30 to 60 milliliters over 10 to 30 minutes through a central line.
Yep, that's the standard.
But here is the kicker from the literature. A recent massive study, the Center TBI trial, looked at these two heavyweights across thousands of patients and found absolutely zero difference in ICU mortality.
None.
Or in 6-month functional outcomes. So here's where it gets really interesting. As the attending, if the outcomes are statistically identical, how do you actually make the call on which one to prescribe when I'm standing there with a crashing patient?
That decision, that is the art and science of neurocritical care right there. Because the brain-specific outcomes might be similar, but you have to look past the brain. You have to look at the rest of the body.
Okay.
You choose based on the distinct side effect profiles of the drugs and the patient's current systemic status.
So break that down for mannitol.
Well, mannitol is an osmotic diuretic. So not only does it pull fluid from the brain into the blood, but it travels to the kidneys and physically forces them to diurese massive amounts of free water.
Which can cause profound hypovolemia and hypokalemia.
Exactly.
And if you push the doses, say, more than 200 grams a day, you risk acute kidney injury just due to the high osmolar load on the renal tubules.
Precisely. So let's say you have a polytrauma patient who is already hypovolemic from internal bleeding, or maybe someone with borderline kidney function. Mannitol might be a terrible choice.
Because you'll drop their systemic blood pressure.
Right, which drops their cerebral perfusion pressure, completely worsening the brain ischemia.
That makes total sense. And then you look at hypertonic saline, it pulls water from the brain, but it doesn't force it out through the kidneys the same way, right? It acts as a massive intravascular volume expander.
Right, which is fantastic if you have a hypotensive patient.
But I'm guessing that rapid volume expansion risks causing cardiogenic pulmonary edema if the patient has a weak heart.
You're exactly right. Plus, it drives severe hypernatremia and hyperchloremic metabolic acidosis.
So the underlying question during every single crisis is really, what can this specific patient's heart and kidneys tolerate right now?
Exactly. The choice isn't about which drug is, quote-unquote, better for the brain. It's about which drug is safer for the body that is keeping the brain alive.
It's all highly individualized. You aren't just treating a swollen organ, you're managing a really complex, interconnected physiological system. But, once we've selected our tool, whether it's mannitol or hypertonic saline, how do we actually deploy it? The literature presents two main algorithmic pathways for managing these crises. And which one you use entirely depends on your hospital's resources.
Right. SIBICC and CREVICE.
So let's dive into those.
The fundamental divide between these two protocols really comes down to one thing: data. Specifically, whether or not you have an invasive ICP monitor.
So a physical probe drilled through the skull and placed directly into the brain parenchyma to give you real-time, continuous pressure waveform.
Exactly. Let's start with the data-rich environment. SIBICC is the consensus algorithm for when you do have an invasive monitor.
Right, and it relies on strict numbers, escalating therapies when the ICP hits that critical threshold of 18 to 22 millimeters of mercury.
Right.
But what really fascinated me in this SIBICC protocol is the use of a MAP challenge to test something called static pressure autoregulation, or SPAR.
Oh, this is one of the coolest concepts in neurocritical care.
Yeah. Because if SPAR is intact, the protocol says raising the patient's mean arterial blood pressure actually lowers their intracranial pressure. Intuitively, that feels completely backward to me. If pressure in the brain is too high, why would driving systemic blood pressure up help?
It totally feels backwards, but it's a brilliant physiological paradox driven by the myogenic response of the cerebral vasculature.
Okay, walk me through that.
If autoregulation is intact, the blood vessels in the brain are still functional. When you drive systemic blood pressure up with vasopressors, those cerebral vessels literally sense the higher pressure hitting them.
Okay.
And to protect the delicate capillary beds downstream and maintain a constant blood flow, they constrict.
Ah, I see. By constricting, they narrow their diameter, which decreases the overall volume of blood sitting inside the cranial vault at any given second.
Precisely. You decrease the intracranial blood volume, which drops the intracranial pressure, and you do all this while maintaining cerebral perfusion.
That is amazing. So SIBICC allows us to dynamically test this autoregulation and individualize our cerebral perfusion pressure targets, usually aiming between 60 and 70. It's highly tailored medicine.
It is. But then we have CREVICE.
Right, CREVICE. This is the consensus-based protocol designed for patients without an ICP monitor.
Yes, which happens a lot. You might be in a resource-limited setting or simply waiting hours for a neurosurgeon to arrive.
So CREVICE relies on scheduled hyperosmolar infusions every 4 hours, deep sedation, and continuous 3% sodium chloride infusions, and it's guided purely by clinical exams and serial CT scans.
Right.
I gotta admit, looking at this, without a pressure bolt in the skull, aren't we just flying entirely blind? I mean, we're throwing massive osmotic loads at a patient, but we don't actually know if the pressure is down or if the brain is just temporarily accommodating the swelling.
Your concern is highly valid. It is absolutely a less ideal, much more dangerous situation. Relying solely on clinical exams and serial imaging is fraught with danger.
Because it lags behind.
Exactly. Those indicators severely lag behind reality. By the time a pupil stops reacting, or a CT scan shows midline shift, the pressure has already been critically high for way too long. The damage is done.
Wow.
CREVICE is a necessary, brilliant safety net for resource-limited settings. I mean, it gives clinicians a structured way to save lives when monitors aren't an option, but you are operating in the dark.
You can't calculate cerebral perfusion pressure.
No, and you run a massive risk of either overtreating and causing organ failure or undertreating and just losing the brain.
So if you find yourself in a CREVICE situation without a neurosurgeon to drill a hole, are you just entirely out of luck for real-time data? You just have to guess?
Well, not necessarily anymore.
Because this is where the literature transitions into something truly exciting, the rise of non-invasive neuromonitoring. I mean, it feels like science fiction becoming reality.
It really does. The advancements in this space are aggressively bridging the gap between the blind approach of CREVICE and the invasive gold standard of SIBICC.
We are finding these incredibly ingenious ways to measure what's happening deep inside the cranial vault, but using proxies from the outside.
Exactly.
Let's look at the 3 specific tools highlighted in the sources. First is ONSD, or optic nerve sheath diameter. You literally put an ultrasound probe over the patient's closed eye.
Yep.
And why does this work? Because the optic nerve is physically contiguous with the brain, and its nerve sheath is a direct extension of the duramater, surrounded by cerebrospinal fluid.
Right. When pressure goes up in the brain, it physically pushes CSF down the optic nerve sheath, ballooning it out.
And the data shows that an ONSD of 5.3 millimeters or greater correlates strongly with an invasive ICP of over 20.
It's a literal window into the brain. It's rapid, bedside, and it gives you actionable data.
Then there's NPI, the neurological pupil index. Instead of a nurse just, shining a pen light and charting sluggish, which is incredibly subjective, you use an infrared camera, a quantitative pupillometer.
Much more reliable.
Right. It calculates a hard objective number based on constriction velocity and latency. An NTI of less than 3 indicates decreased reactivity, and that number drops proportionally as intracranial pressure rises.
It takes the guesswork completely out of it.
Finally, and honestly, this is the most mind-blowing one to me, is non-invasive ICP waveform analysis.
Oh, this technology is incredible.
You put a tension gauge sensor on a headband around the patient's head. It measures microscopic nanometer displacement like the actual stretching of the rigid skull bone with every single heartbeat. From that, it calculates a P2 to P1 ratio.
Let's break down those waveforms because the physiology is so elegant.
Please do.
So with every heartbeat, a pulse of arterial blood hits the brain. That's your P1, the percussion wave.
Okay.
Immediately after, the brain tissue recoils against that pulse. That's your P2, the tidal wave, which represents the brain's compliance.
So what does this all mean for the clinician at the bedside? Like, how do I use this?
Normally, P1 is taller than P2. The arterial pulse is strong and the brain easily absorbs it. But when the brain is swollen and stiff, when compliance is gone, that P2 wave spikes.
Oh, because the tissue can't absorb the pulse, so it aggressively rebounds.
Exactly. If you look at that non-invasive headband monitor and see the P2 wave rising taller than the P1 wave, you know the brain is incredibly stiff. You know a crisis is imminent.
We are essentially using the microscopic stretching of the skull bone as a highly accurate proxy for intracranial compliance.
We are. And what it means is that we are regaining our sight in the dark. These non-invasive tools, I mean, they don't completely replace the continuous accuracy of a direct pressure bolt just yet, but they allow clinicians to track the trend of the brain's environment in real time.
So if you see the optic nerve sheath widening on ultrasound, or the NPI dropping from a 4 to a 2, or that P2 wave climbing,
You know compliance is failing. You can catch that physiological deterioration and escalate your hyperosmolar therapies before the patient drops a motor point on their GCS.
you get ahead of the crisis instead of reacting to it.
Exactly.
It's incredible. It gives immense analytical power back to the bedside clinician, even when surgical resources are, completely scarce.
It does.
Right.
But we have to remember to integrate all this data, the ultrasound, the pupillometer, the waveforms, into the holistic picture of the patient.
Which brings us to our final takeaway. To summarize for you listening, managing an intracranial pressure crisis is the ultimate race against time and physics. It requires a meticulously tiered, logical approach.
Absolutely.
You have to build the physiological foundation with Tier 0, optimizing venous drainage, strict temperature and glucose control, and maintaining euvolemia with 0.9% normal saline.
Right.
Then you bring in the heavy-duty Tier 1 hyperosmolar therapies, mannitol or hypertonic saline, carefully tailored to what the patient's systemic hemodynamics and kidneys can actually tolerate.
Great.
Ideally, all of this is guided by the continuous dynamic data of a SIBICC approach with an invasive monitor. But increasingly, when that isn't possible, we are heavily augmenting protocols like CREVICE with futuristic, non-invasive tech to track those vital compliance trends.
And if there's one core insight I really want to leave you with, it's this. Treating an ICP crisis isn't simply about making a number on a monitor look good, whether that number comes from a drilled skull bolt or an infrared camera on the eye.
Right.
Our true goal is preserving the delicate microscopic balance of cerebral oxygen delivery and metabolic consumption. We are managing the intense physical constraints of the skull to save the vulnerable neural networks inside. Ultimately, we are fighting to save the person behind the patient.
That is the perfect way to anchor this incredibly complex topic. And it leaves me with one final provocative thought for you to ponder long after this deep dive ends. We talk in the very beginning about how the skull is a rigid vault, a fortress.
We did.
And for decades, our only reliable way to know what was happening inside that fortress was to physically drill through the bone. But considering the rapid rise and refinement of non-invasive technologies like tension gauges measuring nanometer skull displacement and infrared cameras mapping pupillary reflexes with perfect accuracy if these tools become flawlessly precise, will the gold standard of drilling a hole in a patient's skull eventually become a barbaric relic of the past? Could the future of neurocritical care truly become entirely non-invasive?
It's a fascinating horizon.
Yeah.
And honestly, it's one we might see in our lifetimes.
Something to keep a very close eye on. Until next time, keep questioning, keep learning, and thanks for joining us on The Deep Dive.